start his talk.
Yeah. Thank you so much, sir. Thank you. Sir, am I audible?
Yeah, you are audible.
Slide, sir. Visible, sir.
Yeah, visible.
Yeah. So good evening, guys. Next few minutes, I'm going to talk regarding the management of ECMO in a nutshell. So I'm going to talk on different topics and different management perspectives. So obviously, I don't have any conflict of interest here. The objectives of talk are going to be in terms of initiation, maintenance part, a weaning part, and then the post-weaning care also, which is also most important part here. During initiation, I think by this time, every one of you might have known how to select a cannula, how to place a cannula, what is the technique behind placing the cannulas, where to fix the cannulas. So apart from knowing all these things, what I'm going to suggest for every one of us, for whoever is an ECMO physician here, try to maintain ECMO crash cart here. So if at all, if you're going to initiate a VV ECMO, we don't know when you're going to convert back into a BA ECMO. You might land up in a cardiac arrest, or you might land up in a situations where you need to convert your ECMO to any other form of a hybrid modes of ECMO. So for that, you need to have an ECMO crash cart. Crash cart should be always primed and kept ready. And what are the various parts of an ECMO crash cart that are supposed to be there? So once you're planning ECMO for any patient, don't try to initiate ECMO on a peripheral venous axis basis. So it should be always try to place a central line on the left jugular side, and then keep one port in the central line ready for giving the drugs or infusions during your ECMO cannulations. There might be arrhythmias, there might be hypotension that is happening. So you need to have one extra port in the central line, primed and kept ready with an extension line, and then that extension line should be given to one separate person who is handling the patient monitoring and vitals. And all the drugs like noradrenaline, vasopressin, adrenaline, and all those drugs should be loaded along with the flush. You need to have an ultrasound machine. I think every one of us know here. And you need to have a Vigon ready also. The reason why I'll keep a Vigon ready, So once even I'm initiating a VV ECMO, I'll place this Vigon into femoral artery. So once my femoral artery access is ready with a Vigon, so in case of a cardiac arrest, what I can do is I'll simply convert a VV ECMO into a VA ECMO by introducing a guide wire into your Vigon immediately. So otherwise, if it is not getting converted, you can use the same arterial line for the monitoring purpose also. And you need an extra femoral arterial cannula, which is of 19 size or a 21 size, kept ready. And you need to have a connectors also. So all these things should be kept in an ECMO crash cart, apart from your initiation protocols and all. So every center which is practicing ECMO, I suggest to maintain an ECMO crash cart with all these lines, with all these extra cannulas, with all the extra connectors and tubings, and with all the drugs that are necessary for initiation of the ECMO here. Coming to the maintenance part, how do you manage the maintenance of an ECMO here? It's broadly divided into anticoagulation part, hemodynamic management part, the ventilation part, the sedation and analgesia, gas exchange and tissue perfusion part, generalized nursing care and management. So anticoagulation part. So what is the reason for So the reason to have an anticoagulation again here is, so every circuit or any extracorporeal circuit, if it comes in touch with the blood, it tends to have a thrombosis here. So to balance your bleeding and thrombosis coagulation parameters, you need to have an anticoagulation for all extracorporeal circuits. And what are the various drugs available, which I'm going to tell you in next small slides. And what is an ideal agent for maintaining your anticoagulation in ECMO? So you have different drugs that are available in the anticoagulations chart. You have parenteral and oral. In the parenteral, you have direct and indirect. Oral again, direct and indirect. Of these part, the first drugs which you are dealing with are unfractionated heparin or a low molecular weight heparin, which comes under parenteral indirectly acting anticoagulants here. So unfractionated heparin, the most commonly used drug for maintaining the anticoagulations in ECMO. So the bolus dose of the drug, every one of us know this here, 50 to 100 units per kg should be given with an infusion rate of 10 to 20 units per kg per hour, and it should be titrated to the effect. So what is the effect? How you calculate the effect based upon the heparin dosages? You can calculate the effect based on your ACT times, activated clotting time, or you can measure your APTTs, or you can measure your anti-factor 10A levels, which is actually a gold standard for measuring the heparin activity. You can also do TEG levels, TEG monitoring also in case of any discrepancy here. So once you know, once you start using heparin, you need to understand various parameters where there is an increase and decrease in the heparin requirements that happens in a particular patients. So say for example, if there is a blood products transfusion, or if the patient is having a dehydration with an increased urine output. So in those situations, the heparin requirement will increase. So you need to increase the dosage of heparin when you're transfusing blood products to the patients, and when you're dehydrating the patients by terms of any Lasix infusions or decongesting the lung. In those situations, your heparin requirements will increase. In situations like renal replacement therapies and clots or sepsis inside the circuit, your heparin requirement will decrease here. Okay, so you need to understand what are the various situations where heparin requirement increases and decreases. And the bolus dose, which is given during the initiation of ECMO, should be given once the guide wire is in. Once the femoral guide wire is in, you need to give the heparin bolus, titrating the ACT levels. And whatever might be the test you are using here, ACT, APTT, whatever might be the test you are using here, the target is to reach a heparin concentration of 0.1 to 0.25 units per ml. So to get a heparin concentration of 0.1 to 0.25 units per ml, that is a reciprocation of around 200 to 250 of your ACTs here. So coming to the heparin, it's an indirectly acting, it acts through antithrombin 3. It's an activator for antithrombin 3, and heparin antithrombin 3 complex goes further and activates so much coagulation systems. So inhibits so many coagulation systems, leading to anticoagulations here. So heparin resistance, all of us know, if the heparin requirement is more than 35,000 units per day, which is unable to which is unable to maintain the ACT levels, you call it as a heparin resistance. You call it as heparin resistance. And how do you deal with the heparin resistance? So you need to deal with the heparin resistance by converting from a conventional unfractionated heparin to NOAC therapies. You can use biliverdin or directly acting agents can be used in these situations. And with heparin, the most common side effects being HIT type 1 and type 2. As we all know, the most common type of HIT is around type 1, which is 5 to 10% chances. Type 2 is 0.0 to 3% chances. The immediate exposure is seen in type 1. Delayed exposure is seen in type 2. In both the situations, platelet will be decreased to 50% of the base value. But the most complicated one being heparin type 2. HIT type 2 is most complicated thing because thromboembolic events are common in HIT 2 here. The treatment type for type 1 and type 2 is suspension of heparin. Stop heparin. You can immediately convert the heparin into, you can immediately convert from heparin to direct thrombin inhibitors or heparinoids can be used. Even you can also use diclofenac. So let us see what you have done till now. What are the various tests that are available for dealing for measuring the heparin activities? ACT. The advantage of ACT being it is inexpensive. It's a point of care test. It's a whole blood test, just like your TEG. It's a whole blood test. But the disadvantage is it measures the end point of the coagulation cascade. So it does not tell you about exactly about the unfractionated heparin effect, but it tells us about the endpoint. APTT is an intrinsic pathway and a common pathway. It measures the common factors that are present in intrinsic pathway and a common pathway here. And it's not a point of care test, but now it is becoming a point of care test that is available. But the main disadvantage of APTT is intra and interpatient variability is there, especially in infants, and less reliable in critically ill patients. That's a major disadvantage with APTT. Anti-factor 10A levels, which is actually considered as gold standard for monitoring the heparin activity. It specifically measures the unfractionated heparin activity based upon the ability of the unfractionated heparin to catalyze the antithrombin's inhibition of factor 10A. So it is better associated with unfractionated heparin dosages here. But the major disadvantage of anti-10A levels again here is whenever there is a hemolysis or whenever there is a jaundice, like elevated plasma free hemoglobin and hyperbilirubinemia, it will always underestimate the activity of the heparin by anti-10A levels. TEG and ROTEM, yes, it's called as point of care test. It's a whole blood test. It gives information about clot strength and even after the clot strength, fibrinolysis also. But the major disadvantage of either TEG or ROTEM is being the limited availability of the test here. So once your unfractionated heparin is done, so if there is any complications like heparin-induced thrombocytopenia type 1, type 2, other situations where the thrombocytopenia is persisting, you can immediately convert from an indirect parenteral heparin to direct acting thrombin inhibitors. So you have many more examples here. You have bivalveridin here, argatroban and heparidin. So what are the various advantages of direct thrombin inhibitors? What are the disadvantages of direct thrombin inhibitors and dosages? The advantages being there is no cross reactivity with the heparin. It's active for both clot-bound heparin and clot-bound thrombin and free thrombin in the circulation also. There is no need of any cofactors like heparin requires antithrombin 3 levels in the blood, and direct thrombin inhibitors does not require any cofactors. So that's the major advantages. The disadvantages of direct thrombin inhibitors being the cost and difficulty in measuring the anticoagulation effect. Conventional ACT assays are generally unreliable if you are using a direct thrombin inhibitors, and there is a lack of reversal agent for all the direct thrombin inhibitors. So that's a major disadvantage of all these direct thrombin inhibitors. Coming to the dosages, argatroban it should be given at 0.2 to 10 mics per kg per minute. Bivalidine 2.5 mics per kg per minute. Lepridine 0.1 to 0.4 mg per kg per hour. If you compare various commercially available direct thrombin inhibitors, the one with the least T-half being is bivalidine, which is a semi-synthetic Hilulog. Lepridine 1.3 hours and argatroban is around 39 to 51 minutes. Of all these three, bivalidine is enzymatic elimination. Only 20% is renal elimination, so it can be easily managed whenever the patient is having either hepatic or renal dysfunctions here. The monitoring part, APTT is generally used. It's not 100% reliable, but it's almost, if you use the APTT trend, even APTT is also reliable in case of direct thrombin inhibitor activity measuring. Reversibility with the thrombin binding, argatroban is reversible, lepridine is irreversibly binding, bivalidine is partially reversible. There is no antidote here. Recently, bivalidine antidote is coming into the market, but not commercially available in India as per now. So you have done the anticoagulation management. So coming to the hemodynamic management, what are our targets here? So it's like generally any other ICU targets, your target heart rate should be around less than 110 beats per minute. Target of MAP more than 65 millimeters of mercury. Targeting urine output more than 0.5 ml per kg per hour. And target the lactates less than 1 millimoles per liter. Target saturation based on type of ECMO. If it's a VV ECMO, the saturation target might comes around 80 to 85. If it is a VA kind of ECMO, the saturation target is always the 100. Coming to the ventilation strategies. So once the patient is on a VV ECMO, what should be your ventilatory settings or the ventilatory strategies? There is something called as a rule of 10 here, wherein we will adjust the settings in such a way FiO2 is the least acceptable FiO2 with a PEEP of 10, pressure support of 10 and the respiratory rate of 10. So you can simply remember it as a rule of 10. And monitoring part in a ventilation strategy, routine ICU monitoring. It's like any other routine ICU monitoring. Just like monitoring your PEEP, monitoring your compliance, monitoring your tidal volume, PPEs and FiO2s. All these things should be monitored. Coming to the management of sedation and analgesia. So what are our goals of sedation and analgesia in an ECMO patient? The reason for starting any sedation or analgesia is decreasing the pain and anxiety of the patient, decreasing the stress response, decreasing the oxygen consumption as much as possible, and maintaining the patient and ventilator synchrony. And by doing all these things, what you're going to achieve, you are going to avoid neurocognitive sequelae in ICUs like depression, post-traumatic stress disorder, dementia, and anxiety here. So, and always by doing complete sedation and analgesia, the most important thing is you are making the family accept the care of the ICU. So the patient is completely sedated, the family is not going to accept that. The patient should be partially sedated, and whenever you are going to waken up the patient should respond to your commands. That should be your goal here. So by doing this, yes, you are making the family as a part of the treatment, and then family acceptance of the ICU care increases if you optimally manage the sedation and analgesia in a patient. So coming to the ideal agent, is there any ideal agent for sedation and analgesia? The basic characteristics of ideal agent is being, it should be sedative and analgesic. It should have anxiolytic, amnestic, and anticonvulsant properties. Minimal CVS and respiratory side effects should be there. Rapid onset and offset of action should be there. And no accumulation in case of any dysfunctions, either hepatic or renal dysfunctions. It should not have any active metabolites that are any causing toxic nature to the body. So these are the characteristics of ideal agent, which is very much difficult to find out. So let us see what are the various agents available for management of sedation and analgesia, and let us see what are the various side effects of each and every agent here. So what are the available drugs here? We have so many other drugs like analgesics, like opioids. We have non-opioids like NSAIDs, ketorolac, sedatives. We have benzodiazepines, propofol, ketamine, and we have other drugs, the miscellaneous drugs like we can use etomidate, barbiturates, volatile agents can be tried, haloperidol, quetiapine. Don't forget your antipsychotic agents. With all the sedative measures, even if the patient is not getting sedated, yes, you can try atypical antipsychotics like haloperidol and quetiapine. And alpha-2 agonists, clonidine and dexmedetomidine also can be tried. And ultimately, don't forget your regional anesthesia techniques. Even the regional anesthesia techniques can also be tried, decreasing the pain of the patients. So let us see what are the most commonly used opioids which are there available in the market. So we have morphine, fentanyl, and hydrocodone here. The onset of action, fentanyl has got the lead within 1 to 2 minutes. Morphine and hydrocodone somewhere ranges from 5 to 10 minutes. Fentanyl is being most commonly used. You can use as a bolus dose of 0.3 to 0.5 mics per kg per hour, or you can try an infusion rate of 7 to 10 mics per kg per hour. Coming to morphine, 2 to 4 mg boluses and then 2 to 30 mg per hour can be tried as an infusion. Hydrocodone to 0.2 to 0.6 mg and a bolus dose followed by an infusion of 0.5 to 3 mg. Coming to lipid solubility, fentanyl is of all the three, fentanyl has got the maximum lipid solubility. The morphine's lipid solubility is X, the fentanyl's lipid solubility is 600x, and hydrocodone is least lipid soluble. And metabolites, yes, morphine has got morphine 3 glucuronide and morphine 6 glucuronide. Even hydrocodone has got so many metabolites. Fentanyl in that case does not have any metabolites and there is no chance of histamine release with fentanyl. Morphine has chances of histamine release here. And renal failure adjustment dosages, morphine should be decreased by 30%, whereas fentanyl and hydrocodone no need of any dose adjustments here. So by giving all the drugs, what are the targets here? So whatever might be the scales which are using to measure the sedation in your ICU, where it might be a Riker scale or it might be Richmond scale or it might be Ramsay Hunt scale. So whatever might be the scales here, the targets remain the same. If you are a Riker scale, the target is 3 to 4. That means the patient should be calm, cooperative and sedated. So if the patient is not being touched, he should be calm. But he should be easily awakened following commands also. If it is a Richmond scale, again, the score, I mean, the target should be 0 to -1, alert and calm, and the patient should be little bit drowsy. Or it's a Ramsay scoring system, it should be 3 to 4, awake, responds only to commands, and patient should be slightly in sleep. So whichever might be the scale you're using inside your ICUs, target remains almost always the same here. So gas exchange targets. So once the sedation targets was done, what are the various gas exchange targets? So you need to select an oxygenator for every ECMO patient which is capable of delivering oxygen of around 6 cc per kg per minute. It should be effective in deleting your carbon dioxide from the body and is effective in maintaining the oxygenation. The oxygenation mainly depends upon the flow and the functioning of the oxygenator here. And it also depends upon the hematocrit and recirculation too. So if you have seen the graph here, the graph which was displayed up here, so it's x-axis has got a delivery of oxygen and y-axis has got an oxygen consumption. So if the delivery of oxygen increases, so given the saturation of venous saturation of around 100, the oxygen delivery and then the consumption, the ratio should be maintained in terms of around 1:4. So you need to maintain a saturation target. That's the reason why in a VV ECMO, the saturation target of around 75 to 80 came here. So coming to the downwards graph here, as the blood flow increases, proportionately the delivery of oxygen increases. So you need to select the membrane surface area of the oxygenator with at least 1.5 meters square so that the delivery of oxygen will be corresponding to 6 cc per kg per minute here. So coming to the carbon dioxide removal, it mainly depends upon your sweep gas flows and the blood flows. Once you initiate the ECMO, the ratio of the blood flow to sweep gas flow should be 1:1. The maximum you can go up to 1:2. That means that if the blood flow is around 5 liters, the maximum sweep gas flow you're going to keep will be around 10 liters for any ECMO patient. More than that, the sweep gas flow is not going to remove your carbon dioxide from the system. So coming to the blood flow algorithm, how will you manage the blood flow algorithm in a VV ECMO? So coming to this algorithm, try to concentrate on this algorithm. So whenever you're placing a drainage cannulas or an infusion cannulas, try to place the biggest possible cannulas. And once the biggest possible cannulas are placed, try to increase the flow to the maximum on the ventilatory settings and increase the ventilatory settings too. So once the flow is maximum on ECMO, increase the venti settings and then see the saturation targets. If the saturation is stable, maintaining more than 90% and the flow is also stable, now come back to your rest ventilatory settings to rule of 10 here. So once you're coming back to rule of 10 and then the saturation is maintaining more than 80, that means yes. So this is the best possible scenario wherein you leave the patient on VV ECMO, you'll continue with the lowest flows possible to maintain a saturation of more than 80 until the lung improvement happens. What if if the increasing in the flows to the maximum and increasing in the ventilatory settings unable to reach a saturation of more than 90, that means the drainage cannula which you have added might be small. So you need to add one more drainage cannula here if the flow is a problem. If the flow is not a problem, yes, anemia. Target a hematocrit of more than 40. And even if these two are not a problem, then you should think of recirculation. Maybe the both cannulas are very much close to each other. Try to adjust the cannulas, pulling the femoral cannula a little bit outside. If the saturation increases, yes, you can take, it will be normal. If the saturation is still less than 90, think of other causes. Whether the oxygen delivery has been decreased, or try to maintain the patient's saturation levels by decreasing the oxygen consumption, by decreasing the temperature of the patients. How do you do that? By increasing the sedation or by increasing the paralysis for the patients. So by doing this, your oxygen consumption decreases and your saturation ultimately improves. So this is the basic algorithm for maintaining the blood flows and gas flows in case of a B kind of an ECMO here. Coming to blood flow algorithm in a BA ECMO. So let us see here, venous cannulas and arterial cannulas, it should be biggest possible. In this situation also, increase the flow to the maximum. So once you increase the flow to the maximum, that means what you're doing a total bypass here. In the total bypass, if there is no pulse contour, okay, if there is no pulse contour, try to come down on the flows to the lowest flows, which keeps a saturation, venous saturation target of more than 75, SVO2 of more than 75, and then try to wean the cardiac medications. Once you start weaning the cardiac medications, the patient is stable, fine. Wean to the lowest flows and try to wait for the cardiac improvement. Once you're weaning the cardiac medications here, if there is an increase in the left atrial pressure or an increase in the pulmonary capillary wedge pressure, or if the heart is getting distended, try to vent the left atrium. So there is another class for that, how to, what are the left atrial venting strategies in a VA ECMO, and then try to stay X. In another scenario, if you are unable to reach the maximum flows, that means the venous cannula is very small, try to add it off. And then if the patient is able to tolerate the venous flows, and then weaning of cardiac medication is possible. And in spite after doing that, if the flows were not inadequate, in those situations, try to increase the flows by adding the blood volume and then add wait for till the trial of the patient. So in a VA kind of ECMO, the most important thing is that if there is no improvement occurring more than 3 days after a VA ECMO, try to go for a bridge to a transplant, bridge to a VADS, LVAD should transfer. So this is how you manage the blood flows in a VA kind of ECMO also. Coming to general nursing care, positional changing, like your routine ICU patients, every second of position. Bedsore care, bedsore care and back care is all important. Daily sites. Whether there is a redness, oozing, or color change in the insertion sites. So the temperature should be monitored in the heater cooler unit. The set temperature and the patient's blood temperature. If there is a temperature difference, that's the earliest sign of observing sepsis here. ET and tracheostomy care, like a routine ICU patients, bladder, bowel care, and oral care. These are some of the examples where you need to monitor the limb color of the patient in case of VA ECMOs. You can see the hematomas which are displayed here. So apart from a routine ICU patients, what extra are going to see in the patient when it comes to ECMO, you need to check the neurological status. So once the patient is in a VV or a VA ECMO, patient sedation should be daily interrupted and then check for the neurological status of the patients. Hematomas at the insertion sites, bed sores, bleeding and oozing, positioning of the cannulas. So you can check the positioning of the cannulas either by your chest X-rays or ultrasound, or if your chest X-ray ultrasound is not available. In those scenarios, you can simply mark the cannulas where it got fixed. So, or you can keep a mark on the cannula and then a mark on the skin of the patient so that the cannula has not migrated. You can know that cannula has not been migrated. And you need to monitor your calf tenderness and even for your 5 P's in the compartment syndrome, pulselessness, pallor, pulselessness, pallor, and pain. All these things should be monitored. Distal perfusion. So these are the extra things you need to monitor when it comes to VV or VA ECMO. If it's a VA ECMO, flow in the distal perfusion cannula should also be monitored on a regular basis. Yes, bladders and bowel. Coming to what are the things to be monitored in case of machine, we have so many machines on the bedside. ECMO machine, you need to document your rotations per minute and liters per minute. You need to see the power supply of the machine, and then hand crank should be placed beside the machine in parallel to the original pump head. Clamps in ECMO, remember guys, always it's 6 clamps that is minimum required on the bedside of any ECMO patients. Temperature of the heater cooler unit, which I am quoting earlier. The temperature what you have set and the temperature what it is being given, or the temperature of the blood should be monitored. Sweep gas flows. Sometimes sweep gas gauge also get altered based upon your oxygen bank, which is connected downstairs, and then the FiO2 on the ECMO. These are the basic things you need to monitor. Ventilator, as I already said, volume, compliance, PPX, and routine parameters. Coming to the circuits, what are the things you need to monitor in the circuit? It should be a pre-pump pressure, it should be P-pump pressure called as P1, or it might be a pre-membrane pressure called as P2, or a delta pressure. The difference between P2 minus P3. P3 is nothing but your post-membrane pressure. So delta pressure is difference between the pre and the post. Clots in the oxygenator. Daily there should be a flashlight test on the both sides, pre side and post side in the oxygenator also, so that to identify the clots in the early stage, shattering. So whenever there is a hypovolemia or a hypotension for the patient, what will happen? The venous end of the cannula will start shattering for the flows given here. So once you think the the circuit is shattering, try to come down on the flows a little bit and see whether the shattering is settling or not. If it is settling, that means it's mainly because of hypovolemia. Try to cut the volume status of the patients either by crystalloids or blood transfusions. And then the recirculation part and color change on the circuits, the venous and arterial thing should be monitored. ABG of the circuit definitely monitored. Pre and post membrane ABG should be monitored. Remember, guys, when you are taking a pre and post oxygenator ABGs, FiO2 should be always 1 here. And then any circuit which is normally working in case of an ECMO, it should oxygenate at least 4 times of your pre-membrane. Length of the cannulas, as I quoted earlier, it should be monitored based upon where they were fixed. Pump head auscultation technique. So if you're a good physician on the bedside, just like auscultating the heart sounds and the breath sounds, you need to auscultate the pump head of the ECMO also. So in case of a bearing failure, in case of a clot that is causing obstruction to the bearings, there will be a gurgling sound that will be a new or adventitious sound compared to the previous day. So you need to auscultate the pump head on a daily basis to identify the complications earlier. So coming to the biochemical and lab parameters, it's like routine parameters monitoring. It's not like any specific thing to ECMO. ACT is little bit specific to the ECMO, and APTT in case of any doubt. The target of ACT being around 160 to 180 seconds, depending upon the clinical scenario again. Chest X-ray to see the cannula positions, improvement in the lungs, and any other parameters that has been happening. Platelet counts. Because of resistance in the oxygenator, there is every chance of hemolysis causing thrombocytopenia. LDH, if you think of any hemolysis, peripheral smear. Yes, this is one good investigation that will give us early markers for sepsis, early markers even for hemolysis. CRP and procalcitonin, it depends upon as and when necessary. Pre and post membrane ABG only when you think that the oxygenator is failing or the circuit is getting too much cold. So this is the routine critical care chart which we have developed for ECMO in our unit here, wherein you document different parameters from the machine, ventilator, ABGs, and everything on one side, and it should be done twice in a day. If you have to see, you will monitor the RPM for the given RPM, how much is the flow, LPM, pre pressures, post pressures, delta pressures, FiO2 and sweep in the ECMO machine, heterocoolant temperature difference. If the temperature difference is 0, that means no sepsis. If the temperature difference is more than 1, that means some sepsis is happening. Fast flush done. A fast flush of the oxygenator, whether it is done or not, ACT values, and then the heparin dosage for the same corresponding ACT values, pH, PCO2 and PO2 of the ABG of the patients. Based upon the PO2, you maintain the flows and FiO2. Based upon the PCO2 levels, maintain the sweep gas flows and the blood flows. Compliance on the ventilator to just see whether the patient lung is recovering or not. So all the parameters in the ventilator is only to see whether the patient is recovering or not. So this is a basic critical care chart for ECMO in the ICUs. So that's the reason why you should maintain this, and the trend should be followed for every time. It's not an absolute value you need to see, it's a trend that you're supposed to see. So once you're done all the parts, weaning. So don't forget, once you're coming down on the flows, once you started weaning, you should decrease the heparin requirement. Your heparin requirement might be decreased, or you need to come down on the heparin requirement because before you're going to plan for a weaning. And very carefully with the lung parameters, because in a recovering lung, whenever there is a granulation tissues or a recovering lung, there is a high chances of for pneumothorax causing pneumothorax, and high chances of fistula formations, high chance of alveolar leaks that happens in a recovering lung especially. So when monitoring of the ventilator is much important during weaning. Frequent AVG is just to titrate your sweep and blood flows, and then you can go for a trial off. Trial off will be prolonged in case of a VV ECMO, and a VA ECMO it is shortened with the help of a bridge here. So once your weaning criteria and weaning was done, you need to go for decannulation. And immediately before decannulation, you need to stop heparin. Try to maintain the ACTs around 140 to 160, and then you can go for a decannulation part. Especially in a VV ECMO, decannulation can be done by an intensivist on the bedside, but in a VA ECMO, never take a chance with the artery. So you should always take the help of a vascular surgeon or a general surgeon, wherein the artery closure will be very much easy with a less with a less what is a blood loss in the less blood loss. They can immediately switch at the arteries here. And don't forget the post-weaning care when it comes to ECMO. You need to restart the DVT prophylaxis immediately because the patient is already on heparin since so many longs, and you have stopped the heparin for the weaning part. So don't try to forget restarting the DVT prophylaxis immediately. If the option is there, you can do a DVT screening with an ultrasound. The radiologist is there available in the center. Don't forget the mobilizing the patient. That's the most important thing. Wound care, if there's a bed sore or any wounds. Lower limb Doppler should be documented before and after the weaning care or before and after the decannulation of the cannulas. Hematomas, pseudoaneurysms in case of a VA ECMO should be considered. So I'll conclude my talk here. That's starting from. So every ECMO is different. So you can face complications in your 100th ECMO or your 70th part is much more important. It's not the number of ECMOs you have done and how much you have been mastering the ECMO cannulation techniques. Remember, every ECMO is different. Preparation is the key for the safe landing, and every step during the course. It's just not only the initiation of the ECMO, it's the maintenance part, it's the anticoagulation part, it's the weaning and the post-weaning care. Every step is important. So if you are negligent and if you are kind of celebrating early in case of an ECMO run, you might be end up losing the patients because of DVT and PTEs. So there are instances where the patient recovered from ARDS lung, but we lost the patients with the PTEs pulmonary. So remember, every step is important, and every parameter. Don't try to neglect any parameter that has been given by the machine to you. So every parameter is in information, and every patient is different. You cannot simply say that I'll give heparin boluses of only 50 to 100 units per kg. So sometimes the patient parameters, pharmacodynamics vary. So in those situations, remember every patient is different. The goal of all your management is targeted towards the specific targets. Either it's the saturation targets or the ventilation targets or the sedation targets. Drugs and dosages might vary. So remember every patient is different, but the targets are same. Be prepared for the complications. So don't ever say that I was not prepared for the complications. Just like my teachers used to say, if you don't know how to manage a pneumothorax, don't place a central line. So that's the same way. If you don't know how to convert a VV ECMO to a VA ECMO, don't try to cannulate the patients here. You need to have a proper preparation. You need to have proper planning. You need to know. You need to have some skill in managing the complication at every step of ECMO here. So I'll conclude my talk. Thank you so much.